There. Can you hear me now?
Yeah, Bob.
Hey, Dr. Phil. How's it going?
You already signed in?
Yeah, I'm in.
Oh, I'm in the wrong thing then again. Jesus. Okay. Thanks. Hold on. This is a nightmare.
The wave of the future sucks.
Well, no, I have 3 accounts and it keeps scheduling meetings every day at 5.
Oh.
I don't know how to fix it. I can't talk to anybody because of COVID. They don't have anybody to talk to.
They don't have people working from home for a multi-million-dollar company that is used all over the world.
That's the one. All right, so here's the meeting. So it's open, so why am I not seeing it? And I had no internet all weekend. Nothing.
I'd say maybe it was the weather, but who knows?
No. It was something happened to their Wi-Fi system, so yeah.
No.
And my hotspot didn't work, and it was. All right, why can I not see my screen? All right, can you see my screen now?
Yep.
All right, I guess I'll give everyone a couple minutes.
All right.
Guys, sorry about Thursday. Thank you, Bob. All I had was like 1 bar of cell service. I'm like,
That's fine.
well, we're a little behind, but it's okay. So I think there's just this chapter and then parasitology, and we're done. So there should be 4 tests up already, right? So
Yeah.
Except there was confusion about Unit 2. I guess it was up twice or something weird.
There was, there was one that said pulled questions, and then the other one said like chapter 9, 10, 11, 12, maybe. But the pulled questions was the only one that was up.
Okay. The one that worked.
Yeah.
Okay. All right. Because that's my fault. I mean, people thought they missed something and they didn't. So.
All these tests are due by Friday, right?
I thought it was the 12th. What's today? I thought it was the 12th.
So that's Wednesday then?
Yeah.
All right. Well, here's the deal. The course ends on the 12th, but I have like 5 days where you guys will still have access. So, if I can do it, I'll see if I. Wait, today's the 10th, right?
Yeah.
10th, 11th, or 12th. Yeah, I mean, I can make it due on the 15th if that helps out.
Yeah, that'd probably be a little bit easier for me at least.
Yeah, so I mean, like I said, things will come up, or like Thursday I couldn't get on, so yeah, so I'll record tonight. Is it recording?
Yeah, it looks like it.
Yep.
All right, so we'll record tonight, and then I'll post the tests tomorrow night. You guys will have until Friday to take it.
So how many, do we have a fifth test and then a lab final?
Yes. Now,
Okay.
the lab final will be on just stuff from lecture,
Okay.
anything that would be clinically relevant, like how would you differentiate staph from strap, or how, what it would be very similar. I mean, there's not a
Okay.
lot that I can test you guys on, unfortunately. So as long as we have something in the books, so when you go to apply wherever, I can prove that you took a lab course or whatever. So that's, I guess that's, all we can do at this point in the current.
Yeah.
Yeah.
So. All right, so I guess we'll just get right into this. All right, so I'm going to go over fungus and molds. And remember, if you have fungal infections, it's called a mycosis. All right, so that'll be the word. Yeah, there it is at the bottom. It's called a mycosis. All right, and remember with fungus, it's yeast in the beast, mold in the cold. So it's dimorphic. So depending on the temperature, it will change form. All right, so from what you guys know about mold or fungus, where do you think most of it's going to enter, or where most of it is going to replicate? Anybody have any ideas? Well, it's either going to replicate in the lungs as you breathe it in, or sometimes you can get something cutaneous, so it will be in your skin. These generally will be in the lungs, or they'll be on the skin. They don't like to go deep, all right, due to the temperature. All right, so it is dimorphic, so it will change depending on the temperature, but it doesn't like to get really, really warm. Right? It generally needs some moisture. So molds and yeast are widely distributed in air, dust, fomites, all right, and normal flora. And we can self-inoculate ourselves with Candida or something we have, and if you have an opportunistic infection or if your immune system is diminished, these can take over. Humans are relatively resistant to these. All right. Funguses are relatively non-pathogenic. So most of these are not going to kill you. They may make you sick. And like I said, if your immune system's up and working well, you shouldn't really have a problem. And now remember, fungus and molds, these are eukaryotic. All right, so we're no longer talking about bacteria and prokaryotes. These are eukaryotic organisms. So we treat them with different antimicrobials, and they're going to be a lot of the azoles, and I'll show you that in a minute here. All right, of the 100,000 fungal species, only 300 have been linked to disease in animals. We're only going to go over about 6 of them. All right, so fungus are most common plant pathogens. All right, I'm sure you've all seen fungus on fruits or vegetables or in your garden or wherever. So we use a fungicide if we're farming or we're going to be consuming those, want to consume those plants. So human mycosis are caused by true fungal pathogens. And like I said, a lot of these are opportunistic. So your immune system, if it's compromised, or you've got, cancer, diabetes, or something going on, or your microbiota is diminished, these can become opportunistic. So we'll talk a little bit about histoplasmosis. All right, that's usually from bird feces, and usually it's in the middle of the country or down south. Right? Blastomycosis, Coccidioidomycosis, we'll talk about that, and that's San Juan fever. That's really only in the southwest of the country. Other people, can they get in? Do they need permission? All right. Kate, you're in. Michelle, you're in.
Yep.
Okay, great. All right. All right, so fungal pathogens. True or primary fungal pathogens can invade and grow in healthy, non-compromised hosts. So we'll talk about a few of these, idiomycosis, paraidiomycosis. Those are true pathogens. So even if you're healthy, if you get enough of the infectious dose, if you breathe enough of it in, it can make lobi, it'll make these spores in your lungs. All right. The most striking adaptation to survival and growth is a human host's ability to switch from hyphal cells to yeast cells. So remember, mold in the cold, yeast in the bee. So literally when you breathe it in, it changes shape. All right, so it's thermal dimorphism, grows as mold at 30 degrees Celsius and as yeast is 37 degrees Celsius. So out in the environment, it's usually mold. As you breathe it in or it becomes in your warm environment of your body, it turns into a yeast, all right? And remember, yeast bud, they don't really go through binary fission. It's similar, but the buds are much smaller. So binary fission, when they divide, they're equal in size. These just kind of bud off. And here's the hyphae, all right? So if you don't know what that looks like, just think of bread mold or mold on cheese, all right? So that fuzzy, all right, stuff that's growing, the hyphae, all right? And there's budding. Right, so it kind of divides, but it gives off a little bud. All right, so we have a couple of these that are emerging, and just remember, these are going to usually for immune-compromised individuals. So opportunistic fungal pathogen has little or no virulence. Most hosts must be impaired. So they have very little virulence factors. They don't really have any way of avoiding our healthy immune system. So it's really not a problem unless your immune system is diminished a little bit. Right. So they vary from superficial colonization to potentially fatal systemic. So if they're superficial on the skin or whatever, not usually a big problem. But if they become systemic, if these get deep into the tissues or if they're in the blood, right, can become a problem. They usually don't like that because the temperature's too warm for them. It is a small emerging medical concern, and about 10% of all these are nosocomial infections. Remember, nosocomial infections can be innocuous. It can be just from stepping into a hospital, not even from a procedure. It can be on the doorknob or elevator button or whatever. It may not even have to be from a procedure, just in that environment because there's so much traffic. Right? Dermatophytes, so derma usually means skin, maybe undergo transformation into true pathogens. So if they're growing on your skin and they grow deep into the tissue where they, our immune systems can get to them and they start budding a lot, they can become true pathogens. They become pathogenic. But usually in this country, we catch them fast enough. All right, so epidemiology of mycoses. So how does it transform, or how does it get on us and reproduce? So most fungal pathogens do not require a host to complete their life cycles, and infections are non-communicable. So most, like I said, most mold and fungus, we're not going to be their primary, they're not seeking us out, all right? They don't really require a host because these are saprophobes, so they can actually go in, live off of dead tissue, and consume it for growth. So they don't really need a host to grow. We just happen to become an incidental host. So dermophytes and Candida species naturally inhabit human body and are transmissible. So dermatophytes would be something like Tinea capitis or something that's growing on your skin. And Candida, some of us have it in our normal flora or microbiota, and this would only become a problem if we're immune compromised. We'll talk a little about oral thrush, and you can get a yeast infection. Women can get that if your hormones change or if your immune system is slightly diminished. It can happen. Dermatophytes are the most prevalent. These are things that are going to be growing on your skin. So whether it's on your scalp or your feet or curl in the groin region, these would be the most prevalent. And cases can go undiagnosed or misdiagnosed. So it's more common than we think, but we have enough medication out there now, and people are showering enough and hopefully drying off enough that these things wouldn't stay, or they wouldn't find us that hospitable. So we'll talk a little bit about these, I'm dealing with mycosis. So these would be the true fungal pathogens. So histoplasmosis you know, you can see where the dots are for this. And some of these other ones, Coccidioidomycosis and Paracoccidioidomycosis, these are not going to be up here because of the temperature. So San Juan key fever, Coccidioidomycosis is going to be over here. And when I was in Peru, I was a little bit afraid of, you know, it's Machu Picchu or whatever, kicking up something and getting some of these other things that we normally wouldn't see, but depending on the environment and the heat, we could transmit it. So primary mycosis, remember an infection, yeast infection or a mold infection, we call it a mycosis. Right? So like I said, usually it's going to be the respiratory portal. You're going to breathe it in. You inhale the spores. They start growing as sporulos or spirulos, however you want to pronounce it, in the lungs. And hopefully your lung immune system in your lung, the alpha-2 cells will take care of that. Subcutaneous is exactly what it sounds like. Inoculated into the skin or through trauma. So Sporothrix, some of these rose gardener's disease, the fungus we said before grows on plants. You know, you're gardening or whatever, you scratch your skin, it gets into your skin. The temperature is cool enough, it can start growing, and then it gets into your capillary beds and it can start spreading and get into your lymph nodes and cause some major problems. Right? So cutaneous and superficial would be contamination of the skin surface. So some of the virulence factors is, remember, again, it's thermal dimorphous. So it can change shape depending on the temperature and where it lands. Some of these molds and fungus can give off toxic-like substances. A few of them have capsules and adhesion factors, just like the bacteria. So they can adhere somewhat, and if they have a capsule, it's going to be a little harder for our immune system to consume that and hit it with lysosomes. And remember, once again, these are eukaryotic cells. So these are relatively large compared to bacteria. So they're a little bit harder to get rid of. Hydrolytic enzymes, right, so they can start cleaving things and they can cause major inflammatory stimulants, which sounds like a good thing, except if these are superficial and they're causing inflammation, remember, it makes that tissue very, very swollen, and it opens it up a little bit, so it might be a little bit easier for it to spread with the inflammatory process going on. Antifungal defenses are the integrity of the barriers and respiratory cilia. So we want to make sure that all of our barriers in our respiratory tract are not breached. All right, our skin is not breached with cuts and abrasions or even lacerations or stitches. And we want to have our respiratory cilia. So if we do breathe in these spores or whatever, they get trapped in the mucus of the ciliary escalator. And hopefully we're elevating them up towards the throat and we're expelling them or swallowing them, all right? So just remember, if somebody is a smoker or if they're around a lot of toxic air, it can start killing off the cilia. It can be a major, major problem for them. All right. So most important defenses are cell-mediated immunity. So remember, cell-mediated would be your lymphocytes, specifically your T cells. Right? Phagocytosis want to engulf them and destroy them. And the inflammatory process is going to bring in those cytokines and those chemical mediators to bring all these things to the area of the mycosis. All right, so long-term immunity can only develop for some, and that would be your B cell antibodies to part of the capsule or part of the yeast, some part of the outer wall of that. Hopefully we have a B cell response to that and have some antibodies to it. So diagnosis of mycotic infections. So we're going to view that with a microscope. We're going to stain it. Right? And then we have some enriched media, Sourdough, dexter plates can be used. You can grow them on nutrient agar. Right? And we're going to usually just do biochemical and serological tests. All right, but these are large enough. If you look at them on a microscope, you'll be able to tell it's a yeast or a fungus, but we would know exactly what it was unless, you know, that was your specialty. So we do some biochemical or serological tests to check for antibodies in the bloodstream. Immunization is not usually effective for this. Control involves intravenous amphotericin B, Orzine. And just remember, with any of these fungal infections, usually azole, anything that ends in azole is going to be indicated, and nystatin are usually the most prevalent. Right? All right, in some cases, surgical removal of damaged tissues. All right, so if it's deep in the lungs or if it's deep in the lymph nodes or tissue, there may have to be some surgical removal to get rid of all of that before we can effectively hit it with the antimicrobials. All right, prevention limited to mask and protective clothing to reduce contact with spores. You know, so if you were, you know, if they gave you a case study ever about somebody going, what do they call it, caving, splunking or whatever? So if they're gonna go caving, or they'll give you a specific region, you know, if there was bat or birds or whatever, you inhaled the spores, they give you something in the case study where you would be thinking, oh, they must have inhaled some dirt or spores. You'd be thinking mycosis at that point. All right, so mycoses are presented according to the type, level of infection, and the degree of pathogenicity. All right, so just remember again, true pathogens can get systemic, they can get into the skin, and they can be superficial. And these would be ones that would be a little bit more difficult for your immune system to control. Opportunistic ones, your dermophytes and the Candidus, or the Albicans candidus, or the thrush. Those are things that would normally not be a problem unless you were immune compromised or something was going on where your immune system wouldn't be able to react to it, or you don't have any other competition for it, for that space. It's just showing you here, like with the epidermis, all right, this is all, remember, this is all dead keratinized skin. And these are saprophytes. They can eat their way through this if they want, because they give off, molds and yeast can give off some enzymes and start digesting that, right? But the problem is we don't want it getting into the subcutaneous tissue, right? So if we have the mycosis deep enough where this is eroded away or whatever, it's going to be cool it off, all right? And then once we get into the blood supply superficially, these things can get in the blood supply and they can start budding in there superficially where it's cooler, and then we have a systemic infection and all that lymphatic fluid around here, if it goes into the lymph nodes and starts reproducing in there, we have a major, major problem. A lot of edema, some major issues if it goes untreated. And like I said, we saw that map before. So some of these systemic infections by true pathogens are restricted to endemic regions of the world. So it would have to do with temperature, moisture, and a lot of these other ones that are growing, just remember the weather's so warm that the ground rarely freezes. So these would be growing year round. You know, usually up here when we have a frost or a snow or whatever, the mold or the pollen and things like that, airborne things, are diminished for a period of time. Our infections occur when matter containing Candida are disturbed. So usually, you know, it could be leaves, it could be dirt, San Monkey Valley. You know, people have been known to go dune bugging or whatever in the desert or the dry areas, and they're kicking up all these Candida. They're not wearing masks, they inhale them in, and then we have a problem where someone's digging in the soil without a mask, breathing it in. So these spores are going to germinate in the lungs. The infection can become systemic if the alpha-2 cells don't get it, and you know, I keep reiterating this, but the alveoli are very, very thin. If they break through that, or if they somehow get into the bloodstream from that area, we can have a major, major problem. Spores may be incubated into the skin or inoculated into the skin with Sporothrix, or you know, you scratch your skin and you get these spores directly into your skin, superficially, they can spread. All diseases result in immunity, all right, because once again, your B cells are going to produce antibodies to it, and then we have the memory cells to this, we hope. All right, so let's talk about some of the specific ones. So histoplasmosis, all right, always usually a question on this at some point. It's called Ohio Valley fever. Histoplasm capsulatum, most common true pathogen, causes histoplasmosis. All right, that should be something that everyone's at least heard of. Typically dimorphic, distributed worldwide, most prevalent in east and central regions of the U.S. So it's going to be more on the east coast or in the middle. You know, Ohio Valley is the most common place. Grows in moist soil, high in nitrogen content. So high nitrogen content, we're usually thinking some kind of feces or bat guan or a bird excrement or whatever. So we inhale this, producing primary pulmonary infection that may progress to systemic involvement of a variety of organs and chronic lung disease. So once again, we're going to be in an area where there's a lot of excrement. There's going to be growing in that. They need a high nitrogen content to grow. You kick that up or whatever, and you breathe it in. You don't have a proper mask on, and then we have a problem. So once again, amphotericin B, and once again, it's an ended azole. These are usually the antimicrobials they're going to be using for this. And sometimes they use these for worm infections too, which we'll get to in the next chapter. Coccidioidomycosis or Coccidioidomycosis. I try to say that 3 times fast. Coccidioidomycosis. Distinctive morphology. These are, all right, so when you see these on a slide, they're block-like or brick-like. Arthro-Candida in the free-living stage, and spherules containing endospores in the lungs. So these, literally breathe these in, and they have great big spherules that start growing in the lungs. And these can usually show on a radiograph. Right? Once again, this is valley fever, San Juan Key Valley. So it's going to be Mexico, California, Southwest usually. Lives in alkaline soils and semi-arid hot climates. Is an endemic to the Southwest of USA. Arthrospores are inhaled from dust. Creates these sphericals in the lungs and can form nodes in the lungs. Right. And we'll see a picture coming up. I think there's going to be a kid digging in the soil or whatever, and he breathes these in. I think that's coming up, if I remember correctly. Yeah, so he's digging in the soil here, produces aerosol of arthrospores. So he inhales them in. These are the arthrospores. They look like blocks or bricks. Very, very clear presentation. They start making arthrospores. They get bigger and bigger, and then they just burst, and then they're endospores. So if this kid was compromised or he had something else going on, compromised people can develop meningitis, osteomyelitis, and skin granulomas. This can turn pathogenic if it's untreated. Okay. So this is how bad it can get if it goes cutaneously or systemic. So in here, it's gone through the lungs, it's systemic, and now it's in the capillary beds, spreading. It's just showing you some of the tests. You know, we don't do this in lab or anything, but it's just showing you, there's your control. All right, and this is when you think it is. We get the patient, and they literally grow together, so we know for sure. It's just like the control. It's the same. So Blastomyces, right, dermatitidis, or Blastomycosis is dimorphic. These are free-living species developed in the soil of large section of the Midwest and southeastern U.S. Right, so this is going to be the other side of the country, like Midwestern or southeastern. So it's not going to be quite as dry usually. All right, so these, all right, you guys can see the difference there. Now this is really, really superficial, and that tissue is completely inflamed. So inhaled Candida convert to yeast and multiply in the lungs. And it doesn't take that many. If you look at this, it's relatively pathogenic. You don't have to inhale a whole lot of these. All right, so Blastomycosis, dermatitidis. So remember, this is going to be dermatitidis. It's going to be in the skin. Right? Chronic cutaneous bone and nervous system complications. So you inhale this into your lungs. Doesn't form those spherules, but it gets into the system. And then it becomes very, very cutaneous because it doesn't like, it likes the temperature here much better, but it becomes very, very swollen and red. All right, so we just mentioned Coccidioidomycosis. This is Paracoccidioidomycosis, all right? So this is gonna be even more south than Coccidioidomycosis. Distributed in Central and South America. Lung infections occur through inhalation or inoculation of spores. Systemic disease is not common. And there's, once again, the amphotericin B and the azoles. All right, so, you know, if you were at, they asked you a question about a subcutaneous mycosis, remember that's going to be under your skin. When fungus are transferred directly into traumatized skin, they can invade. Right? So these are not going to be breathed in. I'm not going to say never, but usually always they're never inhaled in. So these are going to be scratch or cut. You're going to pick it up from maybe soil or plant matter. Most species in this group are generally inhibited by higher temperatures of the blood and viscera. They don't like it, so they want to stay superficial. These diseases are progressive. Right. So Sporothrix, schenckii. This is rose garter disease. And you know, I know someone who had this, and it literally infected their skin, their lymph nodes. It was really, really bad. Very common saprophytic fungus that decomposes plant matter in soil. And this person was doing construction and ripping some vines and things out, and he got scratched, didn't think anything of it. Didn't look quite this bad, but it was pretty close. Right? So lymphocutaneous variety occurs when contaminated plant matter penetrates the skin. Pathogen forms a nodule, and these spread nearby to lymph nodes. So the person that I knew got a cut, didn't really do a whole lot about it, and it literally got into the lymph nodes, and literally on the entire arm, right down to the elbow. He was so swollen he could barely bend his arm. It was bad. Because he asked me, he's like, what does that look like? Oh, it looks like Sporothrix to me. He didn't believe me until 3 weeks later when he got diagnosed. Right? Cutaneous mycosis, once again, infection strictly confined to keratinized epithelium, so the skin, hair, nails, dermatophytosis. So this is going to be what we commonly see. Hopefully don't commonly see, but I'm sure we've all seen it. Causative agent of ringworm varies case to case. All right, and once again, ringworm is actually contagious from person to person. This can actually transmit back and forth. All right, so cutaneous mycosis, natural reservoirs of humans, animals, and soil. And the spores, they have to have abraded, cut skin. All right, intimate contact promote infection. All right, so this can be, I know, in high school or whatever, in sports, it can happen. Specifically, wrestling, sometimes it happens. Right? Lung infection period followed by localized inflammation, allergic reaction to fungal pathogens or proteins. So these fungal fungus are going to give off these proteins, and people can have allergic reactions to it. Because even though it's eukaryotic, it's foreign to us. So, you know, here's the ringworm. So ringworm of the scalp, body, beard, or ringworm of the groin and nails. ringworm of the scalp. Hopefully we've never seen this. And, you know, obviously these are worst case scenarios. So tinea capitis. Capitis usually always means head region, affects scalp and hair-bearing regions of the head. Right, if it gets so bad, it will eat right through the follicle, so they'll lose their hair. Tinea barbae would be the beard. Tinea corpus is usually anywhere on the body itself. So if I asked you guys a question, I'll just literally say tinea capitis, and you're just going to tell me what region. You can tell just by what we're asking here. Barbae would be beard, capitis is head. All right. Corpus is usually anywhere in the body. Tinea cruis, jock itch, tinea pedis. Pedis always means foot. Inguinum, right? Nails, the inguinum of the nails. How would you guys like to have that as a patient? Remember, make sure you take their socks off. Check it all out. And I mean, if we've all heard, or if anyone is the athlete's foot or any of those things, tolfinate is usually what they put in all that. All right, Michael, another azole. And the issue with this is you have to apply it for weeks to months. Lamisil, I'm sure we've all heard of that. Here's just some superficial mycosis. All right, so if you see this, these are literally growing on the hair. All right. Elicits mild chronic scaling, modeling of the skin, also indicated in folliculitis. So remember, this can get down into the follicles of the hair, psoriasis of the skin, or psoriatic dermatitis, which is very, very inflammatory and very, very itchy. Okay, so when you look at this, you know, you may think if you're looking at someone's hair, it may look like lice or whatever. It's literally, it's a mycosis, right? Skin. And these are rare because it's living off the dead keratinized tissue of your hair, right? It's gonna have a much better appetite for your skin or your follicles. All right, so we'll talk just about two of these opportunistic mycoses. So remember, they might be part of the normal skin flora, or you know, sometimes the oral cavity, or with females even in the reproductive canal, but your body usually keeps it at bay. But something happens, you're immune compromised, or you're taking immune compromising drugs with a transplant or bone marrow transplant or something. These can become overrun. So Candida, I hope, well, you know, I don't know if any of you have seen thrush, right? So the tongue is all white. We'll see a picture of it coming up. So this is a dominant opportunistic pathogen, not totally uncommon. Aspergillus, this accounts for most lung infections, and these are usually people that are immune compromised. So whether it's HIV or something else, there's usually something going on. So these, once again, these are opportunistic. Candida albicans. Remember, albican always means white. When you see that, it's a widespread yeast. Infections can be short-lived. Superficial skin infections to overwhelming. If they become systemic, they can be fatal because this person's already immune compromised, all right? And this doesn't really have a whole lot of competition. If it becomes systemic, these are great big organisms. The body can get overwhelmed, especially if they're already immune compromised. Right? Budding cells of various size that may form both elongated pseudohypha, so they look fuzzy-ish, or true hyphae. Right? Forms off-white pasty colony with a yeasty odor. Right? I did have a student a few semesters back who when he was talking, I could tell. I didn't want to say anything, but you could definitely see his tongue was white, and it would actually have a very, very yeasty odor, like not to be gross, but like rising bread dough. If you ever smelled that, literally was giving off that odor. All right, so there's thrush. I've actually seen worse. I've seen the entire tongue covered with it. So normal flora of the oral cavity, genitalia, large intestine or skin of 20% of humans, right? Accounts for 70% of nosocomial fungal infections. So let's just say this person was, maybe had some in their normal flora, or they went in for some kind of procedure and got contact with it again. It can happen. So thrush occurs as a thick, white, adherent growth. Some of these have adherence on the mucous membranes of the mouth and throat. And this usually you can't brush it all off. Vulvovaginal yeast infections are painful inflammatory condition of the female genital region that cause ulcerations and discharge. Like I said, usually this is not common, but if the immune system is altered, or sometimes even with menopause or any kind of hormonal change, it can throw off the glycogen content, and these things can start growing. Sorry, so cutaneous Candidiasis, all right. Cutaneous, once again, means superficial. Occurs in chronically moist areas of skin or in burn patients. But still going to look for budding yeast or pseudohyphae are found. If we were doing a lab thing, it would be very, very obvious. Right? I think growth on selective differential media differentiate Candida from other species. Right? We don't do that in lab. But you can see the different, absolute different color formations, and the colonies are still, the borders are very distinct and not irregular. Right? You can see the difference in size. So these are blue and the border is glistening. But you'll be able to tell what species you have from colonial morphology looking at that. If it's elevated or flat, or how it's actually growing. And once again, I feel bad you guys can't see that in lab. So I feel bad. All right, once again, amphitheterin B and azole. So usually in your pharmacology class or boards or whatever, anything that's going to be a mycoses, they're going to give you either amphitheterin B or anything that ends in azole, or it's going to end in azole. It's usually always going to be the answer. All right. Here's Cryptococcus neoformans. All right. So this poor guy is in rough shape, right? Widespread encapsulated yeast that inhabits soil around pigeon roosts, right? Once again, I know I've mentioned a few times about, you know, in the early to mid 80s, these things were very, very common because they didn't know the people with AIDS in these large cities, San Francisco, New York, Houston, or wherever it was growing. These people didn't know they were immune compromised. We didn't have any medication for it. So their immune system, their CD4 cells were completely diminished. Right? So these things were able to take over very, very quick, because without CD4 cells, they're not able to, get those B cells, those naive B cells up and making antibodies and memory cells to this. Infection of lung leads to cough, fever, and lung nodules. All right, so they may have thought they just had a regular cold. Right? Disseminates to the meninges and brain, can cause severe neurological disturbances and death. So yeah, we don't want anything crossing that blood-brain barrier, causing meningitis or any kind of inflammation of the meninges or the brain tissue. It's going to cause some severe neurological disturbances and death. Okay, so usually, once again, biological tests or serological testing is going to be the most prevalent way of doing it. And, you know, if we're studying this in a lab or whatever, it has a very distinctive cell body. And the buds on these are super tiny, relatively compared to the rest of this. Pneumocystis carne Jurvecki. All right. So this is another one of those, I think there's like 9 things, Kaposi sarcoma or some of these other things that are diagnostic for AIDS. All right. So you have to have a CD4 cell count that's below 200 unless they change that. And then if you have one of these concomitant things, it's a diagnostic for HIV and AIDS. It's a small unicellular fungus that causes pneumonia. The most prominent opportunistic infection in the AIDS patients, this pneumonia forms secretions in the lungs that block breathing and can be rapidly fatal if not controlled with medication. So realize it's going to be a fungal infection, right? Cause a pneumonia, right, that causes secretions, and pneumonia causes wet lung, and these secretions are not exactly aqueous, so they literally coat the alveoli. All right, so there's really no diffusion membrane for the oxygen, carbon dioxide and oxygen to go back and forth. All right, so these block breathing, and these people can become hypoxic very, very quickly. All right, Aspergillus, very common airborne soil fungus, serious opportunistic threat to AIDS, leukemia, and transplant patients. So once again, all these things are going to have, this is diagnostic for AIDS patients, pneumocystis carinae, all right, and Aspergillus. So these are all opportunistic, and AIDS patients are people with leukemia. They have a lot of white blood cells, but the shift is to the left, so they're making a bunch of immature white blood cells that are not very effective. So with leukemia, you have a lot of white blood cells, but it's like having an army of 10,000 toddlers. There's a lot of them, but they're not mature. They're not going to be doing any work at all for an immune function. And then transplant patients were chemically diminishing their immune system, so they don't have graft rejection of whether it's bone marrow or an organ. All right, and if you look at this person, all right, we can't say whether he has AIDS or a transplant or whatever, he's immune compromised, but this is literally growing around his eye and the sinus. So infection usually occurs in the lungs. Spores germinate in the lungs and form fungal balls, these large fungal balls, colonize to the sinuses, ear canals, eyelids, and conjunctiva. Right, literally gone in there. All right. And if it's invasive, it can cause necrotic pneumonia. And once again, infection of the brain, it gets past the blood-brain barrier, heart, and other organs. So Zygomycosis. All right, so this, by the way, was not formed from her tattoo. Right? So Zygomycota are extremely abundant saprophytic fungus found in soil, water, organic green food. So remember, these are normal in the environment. They're saprophobic. They're bioremediators. They break things down. We want them. We just don't want to get them into a cut. Right? So, if you're doing any gardening or a cut or whatever, you got to make sure you wash quickly, not a day or two later when it has a chance to start budding. Usually harmless air contaminants invade the membranes of the nose, eyes, heart, brain of people with diabetes, malnutrition, and severe consequences. Right? This person was already immune compromised. Right? And the only thing I want to talk about here would be a couple of these things. So fungal spores are common sources of atopic allergies. Right, and so, right now people are still having allergies. So when you see people out and they're coughing or sneezing, let's not automatically assume they have COVID-19. All right, there's still allergies and dust and these things out there. So we have to kind of keep that in mind too. All right, with seasonal allergies and asthma, farmer's lung, tea picker's lung, bark sticker's disease. So these people are just breathing in these spores or these fungus, breathing it in from different plants through their occupation. Right. Fungal toxins lead to mycotoxosis. So mycosis is a fungal infection. All right. A mycotoxicosis is when these fungus start giving off all these toxins and start causing brain damage or tissue damage or systemic organ damage. usually caused by ingesting or inhaling fungal toxins. So they're really breathing these in, getting into the bloodstream. Aflatoxin are carcinogenic, are grains, corn, peanuts, lethal to poultry and livestock. So if you guys have ever heard about the Salem witch trials, all right, so the people were saying they saw demons and magic and witches and all this stuff. Well, they went back and there's a few accounts of this stuff literally growing in their barns where they were storing their grains and wheats for the winter, and let's say the straw or hay for the livestock, and people were breathing it in. They're having all kinds of neurological defects or hallucinations. All right, so that's what they're saying the majority of this was, as a side note. All right, and Starkey-Boytris, this is sick building syndrome, severe hematological or blood and neurological damage. So this is true, especially in New York City, some of the older Harlem, Brooklyn, they would have people that would go to work in their building or whatever, and they would become sick. And then they would have to take time off. They go home and they get better. Then they come back to work, and within a week or two, they got sick again. And they have these molds and fungus growing in the walls. It's giving off these toxins. It's getting in the air supply. So literally with these buildings, they literally have to knock them down because they're a health hazard and rebuild the entire building. So that does happen. All right. Anybody still with me?
Yep, still here.
Bob, okay. All right. All right. Okay, so. All right, so I'm gonna just start some of the parasitology a little bit. What time is it now? So like, okay, let me just start it. All right, am I still recording? Yeah, okay. Okay, so this will be the last presentation on parasitology. So this will be about all our hemoflagellates. So hemo means in the blood, flagellates, so these are going to be organisms that either they get injected into your bloodstream from an insect bite or whatever, kind of like heartworm in dogs or malaria in humans. All right, we'll talk a little bit about some roundworms, some tapeworms, talk about African sleeping sickness, the Chagas bug, things we're probably not in this country, but things that I've seen show up periodically. All right, so parasitology is a study of eukaryotic parasites. All right, this includes protozoa, so these are going to be relatively large, and helminthes, right, which are worms, cause 20% of all infectious diseases. So it actually is a relatively large group. Less prevalent in industrialized countries, right? Increasingly common in AIDS patients because AIDS patients, once again, they don't have those CD4 cells to regulate their lymphocytes. So they can only rely on the neutrophils, basophils, eosinophils. Their lymphocytes, their T cells are untriaged. They're not triaged. They don't know which antigens to look for and destroy. So it can become a major, major problem. Your B cells are all naive. They're not making antibodies or memory cells. So protozoan and helminthic parasites exist worldwide. Please remember, in third world countries, or we can't even fathom unless you've been to India or some of these places in rural countries, you can't imagine what these people live in, and to them that's normal. They don't know any better. But a lot of these populations automatically, or the majority of them can have a parasite or more. They could have more than one parasite, and to them it may be normal. occur among people in rural, undeveloped, or overcrowded places. And a lot of these can be bloodborne or oral fecal. So if there's an insect vector that bites one and bites the other one, it's going to be transmitted. If it's oral fecal, you know, if they're picking up any of these cysts or parts of these worms and ingesting them, it's good. They're going to have an infestation of worms too. Emerging as serious threats in developed nations. So it is starting to come into other nations. All right, and some of these are becoming more and more resistant to our immune system too. All right, parasitic infections often involve several hosts. Remember, I said before, we have biological vectors, and I want you guys to know the difference between a definitive host and intermediate host. A definitive host, all right, usually has something to do with the transmission of the disease. Intermediate host just kind of carries it from one area to the other. It's just kind of a vector. Usually that host or vector or whatever is completely unaffected by the parasite. All right, parasites can infect humans in one of three ways. So we either ingest them through oral fecal, right? Vector-borne transmission through, you know, could be tick, flea, mosquito, Anopheles, female mosquito, carries more than one disease, all right? And with heartworm, I was just talking to a veterinarian this weekend, and he told me that there's more than one species of mosquito that can literally carry heartworm. So it's very similar to malaria, right, in its transmission. And then direct contact, or, you know, we could be talking about like a loa worm or some of these hookworms with direct contact with, you know, part of it or a cyst or whatever that can actually get into the skin. So acanthamoeba, we're talking about that. All right, Neglari floweri. All right, so those are going to be two that are going to be involved with swimming in more or less stagnant water. And one of these is going to be more directly with eye contact, and the other one's going to be more with a cutter abrasion. But these can get in. Acanthamoeba can literally invade the cornea and destroy it. All right, Neglari floweri can be fatal. If it gets into the past the blood-brain barrier, there's no way to treat it. So the neurological damage is going to be done. We're talking about trypanosome, the kissing bug, Chagas disease. So literally this bug will land on your eyelid or your lip. It actually will take a blood meal, and then as it does it, it goes to the bathroom, and then you go to itch or scratch where it bit you, and you literally take the feces of the parasite, and you actually put it into your own bloodstream. Right? Plasmodium, Wolcheria. All right, so Plasmodium would be malaria. Wolcheria is going to be elephantitis. Right? Female Anopheles mosquito is going to carry both of those. Sandflies, you know, cause Baghdad boils or leishmania. Right? Trypanosome, the tsetse fly. Going to be covering another disease we were talking about. All right, we'll talk a little bit about the Ascaria, a few of these. Giardia we'll be talking about a little bit. Toxoplasmosis or toxoplasma, all right, that's usually carried by field mice, a cat usually involved in the transmission, and then the litter box, and then pregnant moms. We don't want them changing the litter box for fear of getting this. All right, Trichomonas we'll be talking about, that's usually sexually transmitted. So typical protozoan pathogens, these are single-celled animal-like microbes, most having some form of motility. So whether it's pseudopods or if it's going to be flagella, or they're going to have some way of moving. Right? So most propagate by simple asexual cell division of active feeding cell. Remember, we used that term before. Trophocyte is always their feeding form. Right? Must undergo formation of a cyst. Right? So remember, the cyst is when they get expelled or they leave the cell, and that's their little capsule so they can survive outside of a cell. And with a lot of these protozoans, they hope that we consume their cyst, all right, goes into our stomach, and our stomach acid encysts it, starts dissolving that cyst, and then we have the vegetative form of the pathogen in our duodenum and small intestine, and it can start to develop and repropagate. Others have a complex life cycle that includes asexual and sexual phases, and we'll talk a little bit about that. All right, so protozoan are unicellular eukaryotes, all right? And these are really big. We thought, you know, I said the molds and yeast were big. Protozoa are, you can usually see them sometimes with a naked eye. Protozoan enter the body via ingestion and have two morphological forms. So remember, these protozoa, we're going to ingest these and something, right? All right, they have two morphological forms. So the trophozoite is always, I put this in red here for you, feeding and reproducing stage that lives within the host. Right? Cyst, right, is the infective form that survives in the environment. Once again, the protozoan hope that you ingest the cyst, all right, it encysts or uncysts in your stomach with the stomach acid. Then it turns into the trophozoite again, so that's how it reproduces. Undergoes excystment when ingested, developing the trophozoites again. Trophozoites undergo encystment before leaving the host in feces. So the trophozoite turns into the cyst. We consume a cyst, it turns into trophozoite, and that's how the cycle goes. Parasites classically grouped into their mode of locomotion. Right, so we have ciliates. They're going to have cilia. Ventilatum, I think, is the only one we're going to talk about, and that's usually in pig feces or possibly horse feces. Amoeba, so we have those amoebic-like motion. If they have flagella, they're going to be flagellates. And usually we talk about the hemoflagellates, so they're going to hemo meaning blood. The apocomplexans are parasitic, but these lack locomotion appendages and must move by minute contractions of small contractible fibrils, all right? So the apocomplexans, they usually just kind of writhe around and they can wiggle around, kind of like if somebody tied you in a sleeping bag and you had to move around. You could do it, but it would be relatively difficult to have a specific direction or vector to go into. All right. So there's other ones we'll be talking about here. We're not going to talk about most of those. All right, so the cellular and effective stages of the hemoflagellates. So, you know, if they wanted to get really nasty with a board question, they would ask you amastigote, all right, intracellular human macrophages. Right? So these are going to be living in the intracellular and the human macrophages, your macrophages and monocytes, all right. Promastigote. So this doesn't have any kind of locomotion because it's inside of your macrophage, right? It's in there, it's getting a free ride anywhere it wants to go. A promastigote are infected to humans, right? It's got one little flagella on there. Epimastigote, there's a flagella on it. And then trimastigote, these are usually what's going to be floating around in your blood. All right, so entamoeba histolytica. All right, and amoebiosis. All right, so I don't know if you guys have ever heard of Entamoeba histolytica. Usually it causes a little bit of some digestive issues. Alternates between trophozoite, that's the feeding stage, remember, motile by means of pseudopods and a smaller non-motile cyst. So it has these small pseudopods. It can move around. Then it encysts or makes these small cysts, and it hopes that they get excreted and someone else picks them up. Trophozoite has a large nucleus and lacks most other organelles. All right, so entamoeba, histolytica, carried asymptomatically in digestive tracts of humans. Carriers predominate in less developed countries. All right, so there's no animal reservoir that exists, so it literally is covered, it's transmitted from human to human, from human. And remember, it has to be, we have to excrete it into those cyst form, and then someone has to consume it, and the cyst has to turn back into the trophozoite. Infection most commonly occurs by drinking contaminated water. Encystis occurs in the small intestine. Then trophozoites migrate to the large intestines. All right, and then they make cysts, and we excrete them to the large intestine. All right, so there's 3 types of amoeba or Entamoeba histolytica. Right, so just remember when they give you these terms, think of what they mean. So luminal means it stays in the lumen. Asymptomatic infections in healthier individuals. So it stays in the lumen of the small intestine and large intestine, and hopefully we just flush it out with water or whatever. All right, invasive amoebic dysentery. So you probably have heard of amoebic dysentery, right? This is when you have that severe, sometimes colitis, inflammation of the colon. So you have severe diarrhea, colitis. All right, so that would be bloody diarrhea, just about. It can inflame your appendix. So usually this is in the small intestine, travels to the large intestine. But remember, the border between the small intestine and large intestine, the ileocecal valve is right there around the appendix. Right? So it can just easily get into that. And an ulceration of intestinal mucosa. So this is invasive. It gets into the intestinal mucosa and cause some major inflammation. What we really don't want is invasive extraintestinal mucosis. So that just means it's invasive. It got through here, all right, and then it extra intestinal. So it actually left the intestines. And remember I said, if it leaves the intestines, it goes right into that capillary bed, that basement membrane, all right? And please remember, your intestines are a lot of blood supply there because that's where all your nutrients are being absorbed, and they're going to go to your liver, the portal hepatic vein. Amoebic dysentery and invasive extraintestinal amoebiosis can be fatal. All right, so this can be fatal if untreated. So just saying here, the cysts are eaten, all right? Cysts can pass to the stomach. As they pass through there, the hydrochloric acid starts unincysting them, right? Breaking down that cyst. Then we have trophozoites released in the small intestines, and then the large intestines. All right, and it's going to start releasing the cysts again. All right, and that's, you look at that, that is invasive. It literally ate through erosion of the intestine, and you can see all the blood there. Right, that's not supposed to be there. So, you know, there's blood there, and their digestive enzymes start digesting that too. And so it's asymptomatic in 90% of the patients. We hope we just flush it out. It's luminal, we just kind of flush it out. You may secrete enzymes that dissolve tissue and penetrate deeper into the mucosa. So literally eroding that. They're releasing enzymes and digesting that. Causes dysentery, abdominal pain, fever, diarrhea from that colitis, and weight loss. Right? It's carried by 10% of the world population. As normal flora for them. Right. All right, Entamoeba histolytica. So life-threatening manifestations are hemorrhage, perforation, appendicitis, and tumor-like amoebiosis. All right, so, you know, we said if these are extra luminal and invasive, they can get to any, they're in the bloodstream, and if they get to the liver and lungs, they can start forming these great big growths, like they're tumors. So I want to talk about these amoebic infections in the brain. So amoebas, we're only talking about histolytica digestively, but we have Naegleria fowleri and Acanthamoeba. Ordinary inhabit of standing water. So like I said, this has to be some kind of stagnant standing water. So they'll give you a case study of someone, like a family going to a swimming hole or a pond or something where there wouldn't be a lot of moving water. Primary acute meningeal encephalitis, right? So this is past the meninges. Right? So it's inflammation of the meninges, it's encephalitis, so it's going to start invading the brain tissue. is acquired through nasal contact with water or traumatic eye damage. So the person's going to be diving, they're going to breathe in the water through their, nasal cavity. If it's a mouth, it'll go right down the throat. Nasal cavity, it's close enough to the blood-brain barrier there that it can go up through the nasal pharynges. All right, infiltration of the brain is usually fatal. Once again, once these things are huge, once they pass the blood-brain barrier, there's no way we can get to them with any kind of medication, and your astrocytes and glial cells are not going to be able to manage that massive thing there. All right, so here's the difference. Acanthamoeba enters through cut scrapes, the conjunctiva, or inhalation. And this is, what we used to have a problem with contact lens wearers in the late 70s, early 80s. They'd scratch their cornea and they would, use not sterile saline, and they would get these things growing on their contacts and place them in their eye. Keratitis occurs when trophocytes invade the eye. Keratitis, inflammation of the cornea and eye, characterized by burning, smarting, blurring of vision, keratoconjunctivitis. So these people would overwear their contacts, or they have some kind of scratch in their eye, or you can have eye damage. You get into the stagnant water. Somehow these got into your cornea. Neglilar fowleritis infection occurs when swimmers inhale contaminated water. Amoebic meningeal enthesitis may result, causes hemorrhage, coma, and usually death. Right. So acanthamoeba, you generally usually have to have. They'll always put some kind of injury of some kind. So it would have to have some kind of a passageway in. The other one doesn't. You usually just have to inhale contaminated water. All right, and I said the only ciliate we're talking about is Benthidium coli. Right? So if they ever ask you, the most common ciliated amoebic pathogen, this is the only one, Benthidium coli. Inocument of intestines of domestic animals such as pigs and cattle. Horses can carry it too, but usually they'll give you pig or cattle or horse will be one of the choices. So just pick one of those. All right. Acquired by ingesting cyst-containing food or water. So usually it's going to be from feces because it's in the intestines. Somehow that feces is going to get on your hands or in the water supply or whatever. You're going to ingest these. Trophocyte erodes the intestine and elicits intestinal symptoms, but rarely penetrates the intestine. So what erodes it causes severe, you're severely uncomfortable, and can cause some diarrhea. If you're healthy, it's not going to be a problem. You're just going to really flush it out with plenty of water. So you may have diarrhea for a day, or feel a little antsy. All right, so Trichomonas. All right. So we're going to talk about Trichomonas. These are flagellated, and then Giardia, and then we'll probably end it for tonight. We'll do the last video tomorrow if you want. All right. So Trichomonas. All right, these are small, pear-shaped. So the difference between these and Giardia, these have 4 anterior flagella and an ungulating membrane. So this thing can ungulate back and forth. So these are relatively mobile. This exists only in the trophocyte form. All right, so generally this has to be passed on person to person more directly, usually. Right? Causes an STD called Trichomonas vaginalis. Right. Reservoir is human urogenital tract, so it can live in the urinary tract or the genital tract. 50% of infected are asymptomatic, so males or females could have this with no itching or signs or symptoms. Strict parasite. Remember, this doesn't have this another stage, only the trophocyte. So literally has to be transmitted from someone's urogenital tract to another person's urogenital tract. All right, you guys can figure out how that happens, but that's how it usually happens. 3 million cases a year are top STD. Strict parasite cannot survive long outside of the host. And not to be gross, but this is, another reason why, you know, you're not really supposed to try on bathing suits in the store or underwear because we don't really want, you know, this could be passed theoretically that way, even though these things don't live long outside of the human body. And this is not really something you can pick up on a toilet seat or things like that. Female symptoms, foul smelling, green to yellow discharge, inflammation of the vulva, cervix, urinary frequency and pain. And in grad school, my microbiology teacher was infatuated with this. I don't know what, but so usually you'll always see foul swollen green yellow discharge. Just know it's trichomonas. Male symptoms, inflammation of the ureter, thin milky discharge, occasionally prostate infection, right? But like I said, 50% of these people don't even know they have it. Women, if they have any of these symptoms, generally figure something's going on. Men may not figure this out, and if they, you know, urinate enough, they may be able to flush it out. So that's what trichomoniasis looks like, right? Just thought I'd throw it in there for shock value. Right. So trichomonas, once again, infection of women results in vaginosis, causes this odorous discharge, vaginal and cervical lesions, abdominal pain, painful urination, intercourse if it gets bad, untreated, and usually it's going to have that foul discharge, right? Infection of men, they're typically asymptomatic. We go in and, you know, do a culture and we'd see the trophocytes in the sample. All right, so go over Giardia and then we'll end it for tonight. But Giardia, these are causative agent of Giardiasis, common gastrointestinal disease in the United States. All right, ingested cysts and contaminated food, water, hands. All right, this is really common if places you go don't really have great hygiene. And, you know, another one of those things where they say all employees must wash their hands when leaving the restroom or whatever. All right. Giardia ranges from asymptomatic infection to gastrointestinal disease. So this, you would probably know, you're going to have diarrhea for days or a while. Diarrhea, pain, bloating, nausea, vomiting, and fever. So this wouldn't be an ordinary upset stomach or ordinary flu. This would be a lot of bloating, a lot of diarrhea. You'd be sick. You wouldn't be, this would be seem different than normal, just basic diarrhea from, you know, we talked about like Staph aureus or Bacillus cereus or some of those other organisms that give off toxins. This would be different. All right, so this, you know, sometimes you can, you know, miss this. It would kind of look like trichomonas, but Giardia has flagella on both ends, and it has two nucleus, all right? So, and this has like a suction cup, right? So it looks cute here, really cute little legs and arms and whatever, two little eyes, but not. So this thing literally, the ventral depression, this will literally attach to your intestinal wall, right? So pathogenic flagellate, unique symmetrical heart shape with convex ventral surface that acts like a suction cup. Cysts are small, compact, and multinucleated. Right? Reservoirs include beavers, cattle, coyotes, cats, and humans. Right? Here's the thing. Cysts can survive for 2 months on the environment. It's another one of those diseases you can get from camping or drinking water where anywhere beaver, cattle, coyotes, cats, or anything urinate by a water source, and you can consume these because these cysts can survive for 2 months in the environment. That's why you always want to literally boil any water if you're not sure where it comes through. A lot of these can pass right through filters too. All right, usually ingested with water or food. Once again, effective dose is not much. Same with that Coccidioidomycosis. 10 to 100 cysts enter the duodenum, germinate, travel to the jejunum. Right. first portion of the intestine to feed and multiply. Candidiasis, diarrhea, abdominal pain, remember bloating, vomiting. And here's the key. Diagnosis is difficult because organism is shed feces intermittently. So they could say, well, you know, let's see what's wrong with you. We need a stool sample. You bring it in, nothing. You ask for another stool sample 2 or 3 days later, and then you might have some cysts in it. Treatment, when it was azoles, all right. Agent is killed by boiling, ozone, or iodine. So you always want to treat water if you're unsure. You know, unless you really want some abdominal pain, diarrhea, and a little bit of weight loss, then you know, go for it. Okay, let's end it here. All right, the next section will be the hemoflagellates. So these are vector-borne. Remember, these are going to be transmitted by some kind of animal vector. They're going to be injected into your blood. They're going to be carrying this from their last blood meal, from one host directly to you, but it's going to be vector-borne. All right, so all right, I'll see everyone tomorrow. If not, I'll just record it. And then any questions?
No.
Mm-mm.
Sorry, I'm just getting the voice on. All right, so I will upload this into my YouTube channel and then upload it back into Blackboard for you guys if you want to watch it again. Okay, have a good night, everyone. Sorry about Thursday. Any questions or any problems, or if you need me to reopen something, just let me know.
Thanks, Dr. Phil.
All right,
Thanks.
good night, guys. Thank you.
Good night. Talk to you later.
Come up and eat quick as soon as you're done.